First of all, this type of fracture is common on osteoporotic bones in old age, so it's called osteoporotic fracture, but in young individuals, it's usually a high energy. These fractures are common in females more than males. Fortunately enough, these fractures, most of them are treated conservatively and they are undisplaced. Basic anatomy, we should know there is the head, greater tuberosity, lesser tuberosity, and the shaft. Also here is the anatomical neck and the surgical neck. There is a certain angle, which is the head shaft angle, which is about 130 degrees. Also, there's a retroversion of the head from 18 to 40 degrees. This should be considered during your fixation because this is basic anatomy. There are certain shoulder muscles which control the movement of the shoulder. These muscles later on create a deforming force in fractures. So if you have a fracture of the lesser tuberosity, it's pulled by subscapularis to the inside, medially. If there's a fracture of the greater tuberosity, there's a pull posterior and superiorly by the rotator cuff, and the shaft is pulled to the inside medially by the pectoralis. The blood supply of the head is important. You should know it's coming from the axillary artery through the anterior and posterior circumflex humeral arteries. The anterior circumflex gives the ascending branch and the arcuate vessels which supply the head. You should take care here that these vessels enter the head and pass through the quadrangular space very close to the medial hinge or the medial cortex. Most of us use the Neer classification, but the AO classification is also important, especially in documentation. So we have type A, which is extra-articular fracture, unifocal. Type B, extra-articular bifocal. Type C is articular fractures. We're going to concentrate on the Neer classification. It depends upon the parts. So we have fracture at the anatomical neck, 2 parts. At the surgical neck, greater tuberosity, lesser tuberosity. Or we have 3-part fractures, the head, the greater tuberosity, and the shaft. Or 4-part fractures, where it's a greater tuberosity, lesser tuberosity, the head, and the shaft. Any of these fractures can be fracture dislocation. You stated that a fracture or a part is the part which is displaced more than 1 centimeter or angulated more than 45 degrees. But there are certain points to remember here. Some surgeons consider that the greater tuberosity is a part if it is displaced 5 millimeters, because they consider that this amount of displacement will cause impingement. Also, you should know that 2-part greater tuberosity fractures may be a part of a terrible triad, where there's a fracture of greater tuberosity, anterior dislocation, and axillary nerve injuries. These fractures have very bad prognosis. The lesser tuberosity and the anatomical neck fractures, in cases of posterior fracture dislocation, can happen and they can be missed. In cases of impact fractures in valgus, these are considered innocent fractures and they can be treated conservatively. But in cases of impact varus fractures, or in conditions in which there is over valgus, or there is an angle 180 degrees, these give bad prognosis and should be managed in another way than conservative treatment. How can you predict the vascularity of the head? And if there's a high possibility of vascular necrosis, most of us consider the criteria of Hertel, who mentioned that there's a higher incidence of avascular necrosis if there is a metaphyseal part attached to the head less than 8 millimeters, or if the medial hinge is disrupted, or if there is a fracture through the anatomical neck. So if you have a case with a head fracture and a large piece of metaphyseal bone, this gives good prognosis and you can go for internal fixation. Or if you have a fracture with impact medial cortex, in which there's continuity of the medial cortex, this will give a better prognosis. The radiological workup, the classic, is to do an AP view, do a lateral or scapular view, and do an axillary view, which is difficult in trauma cases. That's why we can use a CT scan. These X-rays are done in an erect position, either standing or sitting. So this is a classic AP view where there's no overlap between the head and the glenoid. the lateral view, the axillary view, which is difficult in trauma patients, but you can do this type of view, which is the apical view, and gives the same information as the axillary view. Is there a role for MRI? It's not widely used in trauma cases and proximal humerus fractures, except if you want to assess the rotator cuff, especially in pre-existing conditions of rotator cuff pathology or in cases of revision surgery. What are the indications? As we said, according to near classification, if there is a displacement more than 1 centimeters, or if there is an angulation more than 45 degrees, especially in multi-trauma patients. But sometimes it's not suitable to reconstruct such types of fractures, especially in low demand patients or in severe osteoporosis, or if there's a high risk of avascular necrosis. In these conditions, it's not suitable to do open reduction, tonification, and fixation, and there should be other techniques to treat this patient by, like arthroplasty. There are different techniques of internal fixation. One of them is the plates, lock plates, but there are other types of fixation like K-wires, percutaneous, or intermedullary fixation, which are not mentioned in this type of presentation. If you see fractures like this, which are impacted with a good head shaft angle, then you can treat them conservatively. But if you have cases like this, fractures with displaced, fracture dislocations, or greatly displaced, greater tuberosity, then you consider open reduction internal fixation. Plates, which give very good stability and are designed to be lock plates, are very suitable for fractures of the proximal humerus, but the technique is very demanding, and you should know the tips and tricks when using these types of fixation, which are mentioned in the coming presentation. First of all, you should correct the head shaft angle, restore the medial cortex. The screws should be hitting the medial cortex and distributed so that they have a firm grip on the head. It should not be high to cause impingement. Should be a space between the tip of the head and the tip of the plate. What approaches to use? The deltopectoral approach is very common and used where you go between the pectoralis and the deltoid, identifying the cephalic vein, and then can you reach the fracture, and you can even extend the fracture, the approach to reach shaft fractures through this approach. It's a very comfortable approach for the surgeons, most of us use it. But there's also the deltoid splitting approach, especially in cases of greater tuberosity fractures, where you go between the anterior and the middle fibers of the deltoid. But in cases where you want to extend the approach, you should identify the axillary nerve, which is about 6 to 7 centimeters from the tip of the acromion. What are the tips and tricks? In your decision making, you should select your patients, and in cases like this, where there's disruption of the medial cortex and high possibility of vascular necrosis during doing internal reduction, open reduction, internal fixation, you should know there's a high incidence of a vascular necrosis and should mention it to the patient. But in conditions like this, where there's a big metaphyseal part attached to the head, although the fracture looks complex, this gives a better prognosis. You should not leave the head in varus. You should always correct the head shaft angle. Otherwise, there is collapse and you lose your fixation. What to do to reduce the head? First of all, you can pass sutures around the rotator cuff if you want to pull the rotator cuff down. Put KOs as joystick for the head. Pass an impactor or a bone lever and push the head, and your assistant abducts the upper limb. You should always insist to correct the head shaft angle and restore the medial cortex. You should always take an X-ray in a view, axillary view, to reduce the head and put it in radial version. Otherwise, there will be collapse and you will lose your fixation. Sometimes there is osteoporosis or severe comminution of the medial cortex. In these cases, some surgeons consider putting an allograft, fibular allograft, to enhance the fixation and prevent the collapse of the medial cortex. But what about of these fractures where there's severe osteoporosis, fracture dislocations, or splitting of the head? Can you do open reduction internal fixation in these cases? I don't think so. And this will be covered in the following presentations. Thank you very much.